Ladies and gentlemen, good afternoon. Welcome to the AMCHAM webinar on healthcare system using genomics to combat COVID-19. I am Michael Claiborne, Government Affairs Manager at AMCHAM. Before we begin today's webinar, I will briefly introduce the program and go over a few technical details. Our program will begin with opening remarks from AMCHAM Chairman and CEO James Kim. Next, we will hear a presentation from our speaker, Dr. David Bentley, Vice President and Chief Scientist of Illumina. Following the presentation, we will have time for moderated Q&A from the audience. Since some of you may be new to using Zoom, let me give you a quick introduction to the software. First, please note that all of your displays and microphones are automatically turned off. After the presentations, you will have an opportunity to ask questions. Please type your question by clicking the Q&A button at the bottom of your screen. Now, I would like to turn it over to AMCHAM Chairman and CEO James Kim for the opening remarks.
Hey, good afternoon and good morning, everyone. Thank you so much for joining us. I'm James Kim with AMCHAM Korea. You know, this is the 10th edition of the AMCHAM webinar series. And as a lot of you know, we launched it in April as a response to the new era of social distancing. And for us, it's been a great opportunity for the AMCHAM community to engage with experts based in multiple countries via the webinar format. And I'm really glad that today, once again, we have a very strong turnout, including not only AMCHAM members, but also the industry from here locally, and both the US and Korean governments. And today, we are so privileged to host Dr. David Bentley, the Vice President and Chief Scientist at Illumina. He's going to shed a lot of new insights on the important topic of this global healthcare response to COVID-19. And because of the webinar's concept, David is joining us from London. He is one of the key scientists at the forefront of research on human genetics. I know that he also played a leading role in the renowned Human Genome Project. David has dedicated his entire career to applying genetics to fight diseases, including most recently COVID-19. And as we all know, an effective healthcare response is the only way the world can win the battle against COVID-19 and hopefully make a full return to normal business and normal life. And no single country can win this battle by itself. It requires a global effort that brings together innovation and solutions from all around the world. And you know, with Illumina, they are a true leader in DNA sequencing and one of the first companies to truly realize the potential of genomics for improving human health. And for the past 2 decades, Illumina has regularly ranked as one of the most innovative and fastest growing companies in the world. And today, we're all counting on Illumina to help us overcome the COVID pandemic. Illumina is also a prominent member of the AMCHAM community, and they are helping to redefine the conception of the healthcare industry. So I hope that today's webinar will help to advance dialogue between the public and private partners and move us closer to the realization of personalized medicine in Korea. I look forward to your participation and a lot of good conversation between all of us. So without a lot of delay, let me now hand it over to our very, very special guest, Dr. Bentley from London. Thank you very much. Dr. Bentley?
Thank you very much. You should hear me now, and I think I should be able to show my slides in a second. How's that? Okay, can you see and hear my presentation?
Yes, we can see and hear your presentation.
Excellent. Just checking, could be 10 minutes before I realize I'm talking to myself. So thank you very much for that tremendous introduction. It's an honor and a privilege to present to this audience. It's given me a chance to dive into some of the details of COVID-19 a little more, to do a little bit of research myself. And I muse on the fact that, of course, genomics is extremely important. Illumina has certainly invested greatly in helping to advance genomics for the world. As it happens, my entire career started with my doctorate when I was actually sequencing an influenza coat protein using nucleic acid sequencing. It took me about 3 months, and I think today one Illumina machine will do it in significantly less than 1 millisecond to generate all that data. So it illustrates something of the speed of genomic and technology development around the world, and of course in particular to harness that revolution, because every living thing has nucleic acid and can be sequenced at the genome level. And you will see something of that interplay today between the genomes of us humans, the hosts, and the patients, and also the genomes of the virus in this case, and how we can use that to really fight and combat COVID-19. So let me start off with a brief summary of what I'm going to talk about. I will spend a little time reviewing the background of what it is, this invisible threat, and how this has impacted us adversely in our ability to combat it, and how we really need to develop an armory very quickly in order to do better. I will then focus on why genomics, and that's perhaps the main part of the presentation, in the sense that genomics plays an important role, as I've already mentioned, with the virus and with the human genome. And I just have a couple of slides to then reflect on what I've been talking about in terms of how we can use this to combat COVID-19, both the impact of the genomics and how it sits in the other elements of research and medical treatments which are emerging around the world, and also to mention something of the ongoing challenges that remain and how the war is far from over. Indeed, there is much still to do. If there's time, I have a few slides just to draw out from COVID-19 and mention how it sits in the rest of genomic medicine. It is certainly true that infectious disease in the last 3 months has gained significantly more prominence, of course, worldwide. And so it now plays perhaps a bigger role of perception in the future of genomic medicine. So let me start with the invisible threat. What does it look like? COVID-19, it is a serious threat to human life. As a virus, it is new. As a disease, it is new to humans, which does mean there is no prior immunity from previous years or treatments available. We really are starting with a blank slate. To add to the complications, and there are more to come later, mortality is estimated now between 30 and 100 times higher than flu. Little hard to get that figure firm because we don't have a good handle on all the estimates. Much is down to modeling, but clearly the mortality is very significant. It also spreads more easily than flu, which adds to the challenge. Mortality, as we all know, I think, but it's useful to revise, it is higher in the elderly. It is higher in those with comorbidities of a wide range, including co-infection by other viruses, as well as diabetes and heart disease and cancer and so on. It is higher in the close living, which of course will vary from region to region, from town to town. And it also appears to thrive better in cool, humid conditions, though that perhaps is less well substantiated at the moment. It seems to spread pretty easily in many conditions. The impact illustrated by the numbers. On February the 6th, there were 31,000 cases and just 600 deaths in the world. Less than 6 months later, we have over 10 million. In fact, we now have over 11 million since I actually prepared this slide of cases. And that's confirmed cases. There may be significantly more. We don't know, because a confirmed case relies upon a positive test result. The deaths is perhaps a number which is easier to understand and record, over 500,000. At the same time, recording deaths is actually sometimes an underestimate or an inaccurate estimate or delayed by times. So how we really project how well this disease is doing or how badly it's doing for us, the numbers are a little hard to really quantify well. I will nevertheless give you some trends to illustrate how this disease has taken our lives by surprise over the last 5 months. Here's the clinical picture for a case. A rapid progression, if you see from day 1 to day 20 is the entire progression typically, though this does vary. The fever and the cough and the hard difficulty of breathing are 3 of the major symptoms illustrated as they develop from day 1 onwards. And in this case, deterioration, of course, in days 10 to 11 typically can lead to intensive care unit admissions. And then in some cases, the host immune response goes into overdrive. And that actually is one of the major complications and life-threatening complications of the disease. It's not the virus itself, it's how we as humans are responding to that virus that sometimes goes somewhat wonky. Main symptoms, of course, is bilateral pneumonia, very severe. Many doctors have never seen anything like it. There are also cardiovascular and other complications. And there is unknown long-term damage. One may recover and leave hospital, but there's significant alteration to the pathophysiology, particularly of the lungs, but possibly also other organs. And so we don't really know what the full impact of this, catching this disease is long-term. One of the impacts, of course, is that people do not all survive. And this illustrates a similar timeline that I've just illustrated here, that the movement onto ventilators, the use of corticosteroids to try to suppress the immune response, unfortunately leading to a death event in this individual. And so these things all happening very quickly, and this is where the frontline workers are tackling the difference between the survivors and the non-survivors with what they have at their disposal. Here's an illustration of the extent of the problem. I've been following these numbers since the beginning, and you can see there are a number of countries. I have plotted out the total deaths per million of population. This is not the total deaths, but the deaths per million of population. And it illustrates, of course, this remarkable transition in different countries. Congratulations to South Korea for being right at the bottom of this plot. The number of deaths per million has been low and remained low. Germany similarly has done well. We don't really know about the Hubei figures. They're not recorded in the Worldometer anymore, and Israel is doing well. By contrast, you can see there, particularly the UK, regrettably is topping this chart at the moment, and other countries variably so. Sweden is an interesting one because unlike most other countries, Sweden has not actively engaged in a lockdown process. I'll say more about lockdown in a moment, but nevertheless, the numbers are going up. So there's a very innate relationship here between the virus and the host, and there are ways in which some nations have been able to really control and alter this shape of the curve more than others. We don't have a curve where no intervention has taken place. We anticipate that it will be much higher. You see there are a few points of lockdown, or in the case of South Korea, a shutdown I've called it, but Diego will be slightly different from a national lockdown process as far as I understand it. And you can see there the various lockdowns. You can see there the UK, for example, was perhaps 2 weeks behind other European countries, Italy. It has been suggested that being late contributes to greater numbers of cases. And so early detection and prevention remains a watchword of if only we could have detected it earlier, then we might have been able to do better. And clearly South Korea and Germany in particular, we know, moved very swiftly and had well-developed testing programs, which actually enabled them to really make a difference to those numbers. The Wuhan lockdown on January the 23rd marks the beginning of this timeline, but of course we do know now there are records that we anticipate indicate the virus was around in December, perhaps even late November, and therefore, because it's an invisible threat, there was no action taken. There could not be any action taken early enough. And that is very different from a disease that recurs year after year, like influenza. When you get to know it, you get to watch for it. And hopefully we will never be in this position again, where the threat is completely invisible. We at least know something about this coronavirus now. Looking at how it spread across the world, I've just illustrated here. These are deaths by country on a daily basis, the gray plots, the bar charts you see there in South Korea, a peak, something in March or mid-March, late March, and dropping off, and the numbers overall very small. The orange numbers are the total deaths, and the purple numbers are the deaths per million. And you can see there a remarkable difference between South Korea, somewhat mimicked in Germany, not as well, but Germany certainly has a similar curve, a similar low number, whereas the UK has higher numbers, and the US, and then to Brazil. What you also notice, the shape of the curve illustrates the peak and then the drop in the number of deaths in the country. The US is slightly behind, and Brazil has now become one of the news centers of the pandemic, and you can see the numbers have risen and perhaps leveled, but they have not actually started to decline yet. And that illustrates how the disease has transitioned from Asia through Europe and into the Americas, starting with North and going to South America as well. So it illustrates a profile of change in terms of the disease monitored by the numbers of deaths. If we look at the cases, they tell a different story. Never such a reliable statistic, but it's getting more reliable now. And you can see here in particular, if I toggle back and forth, you can see the deaths have been dropping down, for example, in the United States on the top left. But the cases now are going for an upswing in the United States. And of course, cases precede deaths. So we might expect this upswing to be reflected in a few weeks' time. So it's a very recent event. It's an early warning sign. There's even a little hint in Germany and perhaps a few cases in South Korea, so indicating it's a somewhat global effect. Although the UK so far has not seen this, nor indeed has New York, which of course was very hard hit first time round. So some interesting observations to make there. Within the United States as well, you see there's New York in terms of the deaths, a huge peak. Ohio and Texas rather more leveled off, and California also level. And once again, if you look at the cases, you now see some worrying upturns across Washington, California, Texas, Ohio, not so much in New York. And again, an early warning sign. This is a pretty major phenomenon that we should be very watchful of what we're trying to do. It's not all over, and we do have an important lessons to learn, and lessons we have already learned to apply to what may happen next, particularly as cold weather comes in the Northern Hemisphere. These conditions may favor the virus more rapidly. But clearly proximity and those things I mentioned earlier may all be contributing to the rise in cases as various countries relax their lockdown on the basis they have to get their economies going. Other deaths will occur for other reasons if the society goes into further decline. And so it's a very difficult balance to strike. But these are the early signs that we have to be very vigilant, and I'll keep on talking about that later. This particular website, GISAID, is a very interesting website. There's a lovely animation which shows the progression of the condition across the globe. You see here that the cases, and this is cases that have had their genome sequenced. The virus's genome has been sequenced from various isolates taken from nasal swabs. And you can see that by looking at the sequences, and I'll say a bit more about this in a moment, the virus was detected in Wuhan and then in Thailand and Australia. And as you carry on through the progression in time, you see it emerge in Europe and then on to the United States of America and a little in Brazil. And this is the gradual transition of the disease across the world. And the color also indicates that the virus is changing as it goes along. And I'll say more about that in a moment. Through to recently, this is April 6th, where the virus was clearly global. There you can still see at this point, South America was less affected than North America. Europe was seriously affected. And you can see that since then, the balance has been changing based on what I showed in the previous slides. So that's just a little introduction as to what the virus has been doing and how serious a threat it is, to illustrate why we should be vigilant and really put all our efforts in partnership, as the introduction mentioned. Partnerships and collaborations are the only way to really combat this. And I'll show one or two examples of that as we go through. So a little bit of background about genomics. The genomes, the pathogen, here is the virus versus the host, which is the human. COVID-19 is caused by this coronavirus, SARS-CoV-2. The virus itself is tiny, 1,000th the size of a human cell that it infects. And the virus genome is also tiny. It's 29,000 bases. This is the 4-letter alphabet, of course. It happens to be an RNA virus. So the 4-letter alphabet is A, C, G, and U. But essentially, when it's converted to DNA, the sequence of the genome is read off as A, C, G, and T. And I will not really make that distinction much more again. The human genome, of course, is something like 100,000 times bigger. That illustrates actually one of the challenges facing us, in that if Illumina and others have focused so much interest on sequencing human genomes or parts of human genomes, we suddenly have to change our focus. The scale is not so well matched to our platforms, and so there's a certain level of rethinking and recalibrating the systems to be able to better handle lots of virus isolates and to do it very quickly and to be able to operate in an infectious disease surveillance mode. So an interesting challenge to technology there to slightly readjust itself. What does each genome sequence give us? So why sequence the genome? The sequence of the pathogen genome tells us how it infects, how it multiplies, how it builds, how it exits the cell. You see there the red, well-known spike proteins on the surface of the virus. There's not much to a virus. There are proteins on the surface, which are the points of attack, of entry into human cells. There's this membrane envelope around it and a bit of nucleic acid or genetic material inside, not much more. The host genome, by contrast, of course, a complex genome, the human genome, but it does include particular areas of interest in this case, which are the point of entry. Where does the virus enter, and are there opportunities to illustrate how well or how poorly a virus may enter a particular cell, and can we block that entry point? Also, I mentioned the extreme immune response of the host in some cases, which is life-threatening, indeed it is fatal, but that is governed by a very complex genetic system, which is not fully understood. But we can look at the genetics of the immune response through the genes and through the genome of the host sequences. We can also look at complications, why the genetics where some people are more susceptible, particularly also the genetics surrounding the comorbidities, such as the heart disease or diabetes, but the genetics of the host can reveal a great deal, which is not only tells us why certain people are severely affected and why it's fatal to some people, but also the same information as we gather it will allow us to better predict who is likely to be more at risk and who may need to be looked at more quickly and more carefully in terms of the care which might be given. And so this early detection, this prediction leads to an opportunity for better prevention. You can prioritize vaccination programs to those who are at high risk or at high exposure. And so genetics and the genomes of both the host and the pathogen will help resolve and improve our ability to target our attack on the disease. So why sequence SARS-CoV-2? I've mentioned somewhat in passing that the color changes in the GISAID website of the global transmission of the virus shows that the virus changes over time. And first off, the sequence allows us to possibly identify has the person got SARS-CoV-2. There are other coronaviruses which are less severe medically, and so it's important to know and differentiate, to provide a differential diagnosis between COVID-2 and other coronaviruses. Just it's also important sometimes to look at what other infections a person may have. The differences between isolates of a virus, so between China and Australia and moving on to Europe, those differences occur as a result of the mutations over time. And you can build a family tree of the viruses. You see there top right, there's a branching tree, an early isolate at the beginning of the year. Take the virus, take a nasal swab from a person who has it in January, and sequence the genome of the virus. And you see there the DNA now sequence of the genome, which has been converted from the virus RNA. And you see a protein sequence, which is actually the function. This is part of the spike glycoprotein. And you can see there a recent isolate later on has a change. A single change in the genome, which immediately reveals the fact that the protein, the spike glycoprotein, has changed. And yes, this is a significant mutation. I've pulled out the example called D614G, which I will talk about again later. The D is aspartic acid, the G is glycine, and that change stabilizes the virus and makes it more virulent. And so it's very important to be able to recognize such changes, particularly in the spike glycoprotein, and to correlate them with the virulence of the virus so that we can better understand when we sequence the next genome, we can perhaps predict and look at suspicious changes versus changes which are likely to be irrelevant or benign. How do we use the sequences then, in addition to what I've already described, particularly, and again, this will be a recurring theme later on, for global and local tracking, we can continue to sequence new isolates as they pop up, and we can map the transmission. Where did it come from? And in future years, we can practice the same process to trace new outbreaks. It is also done for flu and for other viruses, but clearly the seriousness of the impact of COVID-19 and the SARS-CoV-2 virus means that we are likely to do a lot more of this in future years than we have done until now. And so it's a really clear signal to be on our guard and ready to use sequencing for global and local tracking. We can also look at sequences and how they affect future treatment. I've already mentioned the increased virulence example, a new mutation, but a new mutation might warn of a drug resistance. Perhaps it mutates the site of action of a drug, and a new isolate could be added to make a new vaccine in the way that influenza vaccines are evolved on the basis of the sequencing of new isolates. So there are many reasons where the sequence of the genome lies at the heart of understanding the function and the pathogenicity and the threat to humans, the hosts, as well as alongside the host genetics, which I've already mentioned. I'm not going to go into details on methods, but this is just a quick reflection on how to sequence SARS-CoV-2. When you take a nasal swab, there's a lot of nucleic acid in there. There are different viruses, there may be microbes, bacteria, and of course there'll be some human material that has been shed as well. And so you can just take everything, it's a metagenomics approach, and make a library of everything for sequencing. Or you can be more selective. You can enrich for the viruses indicated by the red arrow there. And that gives you information on not just the CoV-2, which in this case is orange, but also other viruses that may be present at the same time. This may be important to establish if people have co-infections. It also may be important to look at, particularly in winter, when people may be sick for a number of reasons. Or we can just focus on CoV-2 by a more specific amplification of the COVID virus sequence, which simplifies the sequencing process but gives you just information about the virus. I'm not going to talk anything about the first two. I'm really just going to concentrate on SARS-CoV-2 focused methods, and I'm just going to go through 3 examples, one only briefly, but just to illustrate how we are using different ways to tackle the challenge of sequencing the genome. Before I get into sequencing, the first COVID-2 test, which is widely used worldwide, is this reverse transcriptase qPCR test. It simply amplifies a small part of the virus genome, and you can quantitate roughly how much of the virus is present. This plot simply shows that multiple labs around the world all get similar results, which is encouraging, but the test is less reliable at a high CT value, less virus, greater risk of false negative results. So you can have a test, you can have a negative result, but you're not necessarily clear of the virus. And that is an important challenge that we will face for some time to come. And indeed, technology can be used to help it. I show here CT30, it means 1,000 viruses per microliter of the solution from the swab. It's just a threshold, and I'll benchmark other methods against that, and I won't pay a lot of attention to it. But much of the benchmarking is against this first test. We don't actually know, it doesn't always work for every time, so the benchmark itself is a little bit of a challenge when it comes to comparing other methods. So here's the first of the sequencing tests. This is the Illumina COVIDSeq test. It's for whole genome sequencing of the virus. It was started as a result of the UK consortium launching providing a grant to launch a consortium to sequence the virus. But it involves partnerships. And the Arctic network in particular, which initially developed these 98 amplicons that are tiled across the entire genome, actually also developed for other technologies, for Oxford Nanopore, but because of the collaborative nature and the importance of the challenge, much of what people have done has been made freely available to others around the world, and that's enabled us to also set up this test alongside. The work was done at the Sanger Institute as well with Illumina to develop the assay itself and the analysis of the results. And perhaps an important milestone was that also the FDA actually provided this emergency use authorization to allow the test to be actually used in a diagnostic system in the United States. And similar national regulatory considerations may be different for different countries. Here's the workflow, collecting a sample from a hospital or clinic. And here are the 6 steps that I've identified as in the clinical laboratory. You extract the virus RNA, you make DNA copies, you then amplify the virus, you make libraries, you sequence, you analyze and report. And the report then goes back to the clinical center for the engagement of the individual. About 3,000 samples are run, illustrates a definite potential to scale up. It's comprehensive data, the whole genome, which means it's a good fit for monitoring changes around the world, the surveillance challenge. It's about a 24-hour turnaround time. Here's a result of an early pilot. That is before the COVIDSeq test was fully implemented, but you can see there that down to that CT30 value, that the genome is very well covered entirely, so you do get very comprehensive data down to below the CT30 value. So it's a very certainly sensitive test and gives the complete information you're looking for sequencing surveillance. And here's a clinical report. We don't need to go into details, but you can see there the test can be used for epidemiology, which is the full surveillance, but also, of course, even if there's not very much virus, if you see some sequence of the virus, you can certainly acknowledge that it is detected, that the virus is positive in this individual sample. You see there on the right the comparison of the COVIDSeq results with this first test, the RT-PCR results. On the whole, very good correlation. Negatives are negative, positives are positive. There are 4 false negatives there with COVIDSeq. They were low CT values. It illustrates that threshold that we need to continue to optimize to look at what are we missing and can we do better and are we doing well enough. Moving on now to a rather different test. The big distinction between the previous one and this one is this is not trying to sequence the whole virus, but this is simply using a very quick, low-cost sequencing test to look at the existence of the virus in a particular sample. So it's trying to go for the high sensitivity, low cost, fast turnaround. Germany in particular, I mentioned at the beginning, was one of the countries that was very vigilant and already had a well-established diagnostic network. And you can see here, as you go through the boxes, there was a very early call for test, adhering closely to the WHO guidelines, a desire for 4.5 million tests per week, that illustrated the commitment in Germany as a whole. And this stimulated, as it does, research and development. And so MVZ in Munich, together with Illumina, they implemented a 3-amplicon sequence assay. So just 3 tiny parts of the virus are now being amplified, not trying to look at the whole thing, with our DRAGON sequence analysis. And then the end-to-end solution was put together, developed by Hasso Plattner and Health Metrics, and a mobile phone network app, which I will just show in a second, for the complete distribution, collection, and delivery system. And just last weekend, a 4,000-person pilot was carried out in Potsdam and Munich by this consortium, and we're awaiting the results as we speak. This illustrates the workflow. It is simpler, as there's only 4 yellow boxes instead of 6. And in particular, the second yellow box is the one where 3 steps have been collapsed into one tube, 1 step. And that is one of the important features of this test. Very simple to carry out. Still involves sequencing and the analysis. In this case, however, very important other difference here is that this is not results being returned back to a hospital center. It's not a clinical diagnostic test. The result has been, the sample has been registered with a barcode to the individual's mobile phone, and the result is returned to that phone, linked to the barcode. And so the individual's anonymity is preserved. And you can see here on the right-hand side some illustrations of the role of the mobile phone messaging system, which provides the barcode which uniquely identifies the sample. It notifies you of the progression or the completion of the results, and it actually notifies the individual of the result. So this is a rather different approach. It is then a recommendation to the individual to act on what to do next if they are positive. Somewhat higher throughput, low cost, and this is therefore a good fit for testing, not for the full sequence surveillance, but it's also very importantly a good fit for asymptomatic testing. And I'm going to say a bit more about this later. But of course, we have a lot of people walking around who have actually maybe got the virus but not showing any symptoms. They may get them later. When we're looking at a diagnostic setting in a hospital, we tend to sequence just those who have symptoms, and so we have a suspicion they have the virus. But if we're talking about people going back to work and setting up workplace clinics to test employees regularly, then the vast majority of people will be asymptomatic, and the vast majority indeed may be negative. And so here we do need a very low-cost, high-throughput test because we're testing many more people. And that's somewhat underlying the 4.5 million tests per week that Germany called for because of the need to test negative and reliably negative for asymptomatic testing. Here's a proof of concept. You can see here once again that a number of negatives, a number of pools and positives, which reveal quite clearly the positive signal. And you can see there the correlation once again with the RT-PCR results. All samples here run in duplicates. Individuals with PCR confirmed CoV-2 can be identified by this testing method. And so far, the claim is sensitivity down to CT30. They're being conservative. We continue to get more samples in. And in fact, the pilot run last weekend will give us a lot more information about just how sensitive this test is. But the early proof of concept was encouraging enough to enable ethical approval and scientific approval for the pilot to go ahead. Just one mention of another, and this is simply a flag to the fact that there are other methods out there. This is attempting to simplify the workflow further. PCR requires a machine that can control the temperature and vary it with each sample. Isothermal, as the name implies, means that there is no such machine required. So this is more low tech at the first stage, although when coupled with sequencing, it remains, of course, high tech at the sequencing step. Also important here, and I've glossed over it, the first yellow box in the previous two workflows involved this extraction of RNA, and that is not only technically challenging, but also it became a supply chain issue because the demand was suddenly so great that the ability to supply the kits to do the RNA extraction was really in doubt, a severe supply chain problem. And so people have been looking at quicker ways to extract the RNA without using such kits. And this is one such example that appears to stand up to a quicker, low-tech extraction process. And this illustrates how much more there is to do in terms of developing technology, how we can move away from complex workflows and high-cost systems, except where we need the whole genome sequence. We can move into testing environments where ever simpler, ever cheaper, and perhaps even moving away from any centralized facility into a point-of-care test or a local clinic will have significant advantages in terms of accessibility and utility of such tests. Also very important and often cited, the nasal swab itself is quite difficult to do. It involves some suffering, and so possibly using saliva instead, which is being investigated at the moment, is a fundamental and straightforward piece of research to indicate, can we get the virus from a simpler sample that can be collected from home or collected without suffering from nasal swabs. Let me just move on now from the virus to the host. It's a rather quick transition, and I only have a couple of slides to flag the fact this work is early stage as yet. But as I mentioned at the beginning, the idea here is that we are able to potentially to look at not just how the virus is changing and becoming more or less virulent and where it came from, but also how the host reacts and what the genetics of the host actually indicates may actually be affecting the severity and may even be predictive. And so this initiative has been set up, once again, global partnership and collaboration. It's a loose consortium in the sense that the straightforward rules are for open sharing of data and discussion and communication of standards and sharing of results. And many people have registered for the Host Genetics Initiative. The great thing was to get such a global initiative recognized and up and running quickly. And this just illustrates something of the partnerships, the memberships, the registered initiatives which are part of this. The number in each circle illustrates the number of initiatives that is included in this particular filter. I think it's the whole genome sequencing filter. And you can see some of the key initiatives there in Canada, in the UK, in Finland, Qatar, India, and over the United States, a number of initiatives. And so these are all at work, essentially addressing an overlapping and similar set of questions using either whole genome sequencing of the human or exome sequencing, or in some cases arrays. So all genomic technologies to say something about the individual variations in the human genome and to correlate that with collected clinical information on the severity of the condition principally. And possibly some other phenotypic measures will emerge as well. Just to touch with one mention of the UK initiative, which I'm of course closest to. Here again, it was funded significantly at the word go. And in particular, it's part of the genetics and mortality in critical care, which is not just about COVID, but it's a national network again, and Illumina has been partnering with them. The program started as a consortium to sequence 20,000 genomes from patients in intensive care, and Illumina also contributed to increase the study to 15,000 patients on top of the 20,000 who had mild or moderate symptoms. And that just illustrates the questions being asked here. Is there something that is systematically different between the genomes of people in intensive care versus the genomes of people who have mild or moderate symptoms? And a very important corollary within the 15,000, we hope, is that as testing of individuals in the population continues, we will identify people who are positive for the virus but are completely asymptomatic. And as you follow on through the next few weeks and months, we will be able to select those that are truly asymptomatic and therefore truly resistant to the condition. And that's a really important area for us to be able to look at. Why is it that some people remain asymptomatic even if they have a viral load? I'll mention a precedent here which illustrates the genetics very precisely, not with COVID-19, but with HIV. When there are individuals who are clearly exposed to high levels of the HIV virus, the high titer virus, but nevertheless remained completely well. And it was revealed that in some of these people, at least, there was actually a deletion in the gene which encoded the receptor by which the virus entered the cell. It was called as a 32-base deletion in CCR5, and individuals with CCR5 were completely resistant to the virus. It's a very simple hypothesis, but the great thing is it has a precedent. Therefore, given we know how the COVID-19 virus ended, people to see if there are mutations in ACE2. Now, to touch on the combating COVID-19, I just have 2 slides here to summarize the features. This illustrates how we are combating the pandemic, and it puts the genomics into the other important elements in the armory of tackling the virus. Testing, do you have the virus today? Of course, if you're negative today, you may have the virus tomorrow, and so the test is only valid for a limited period of time. It started with RT-PCR, and there are now sequencing-based tests. The other important testing, which is not genomics, but it's antibody testing. Do you have immunity to the virus? Have you previously been exposed? And that's a very valuable test, although we don't know formally if antibodies, if you have antibodies to the virus. We don't actually know, of course, if you are immune. In a few months or a few weeks, the immunity may last, it may not. Influenza immunity does not last. And so it's uncertain at this point of what an antibody positive result means clinically, and it will take more time to investigate that. Also, given there are other coronaviruses, of course, not every antibody test may be completely specific for COVID-2, and that's something which is very much in the mind of the test developers. I've mentioned a lot about virus genome sequencing already, the track and trace, the mapping across the world or mapping within a care home, who brought it in, which wards have which viruses, and so on and so forth. The host genome sequencing I've also mentioned, the personal genetics that is possible from host genome sequencing. And then to treatments. And as I mentioned, initially there has been no effective treatment and no effective vaccine. But this is where the future really perhaps it helps. Can we repurpose existing antiviral drugs such as remdesivir, which has proved to be successful, and now the anti-inflammatory drugs which affect or perhaps moderate the human immune response, such as dexamethasone, which can significantly treat the symptoms. And then immunity. I've already touched on the question of, do people develop a natural lasting immunity? We don't know. There are signs of antibody development in patients, and these antibodies indeed have been used. Convalescent patients provide plasma for those who are very sick to boost the incoming patient's immune system. Will it develop to herd immunity, and will it last? or will we be every year looking to renew the immunity program? And can we also develop novel vaccines, again, like influenza? Global vaccination programs may be very important if the immunity doesn't last or if the virus changes. And so these various monitoring to develop treatments and other ways of combating the virus, the pandemic, relate to the genomic information but a much wider community. I just summarize some of the ongoing challenges for a moment to perhaps to focus how all this information relates to our own particular habit. Travel has been an important one. We've talked about lockdown. Travel introduces a new virus into a region. The UK, through surveying sequences of isolates in the UK, found no less than 1,300 separate introductions into the UK. There was no patient zero in the UK, and that illustrates the importance of surveillance to then act upon it in controlling international, national, even local travel. Today, one town in the UK is shut down again, and people cannot come or leave it because we know that the virus has broken out again. I mentioned briefly pre-symptomatic and asymptomatic people. They pass on the virus even though they're not affected, so they have no idea. It remains an invisible threat. And Public Health England estimated some 8.5% of the English population were seropositive in May. If we assume that correlated with 40,000 deaths, that gave this infection fatality rate of 0.8% of the population that is infected actually goes on to die. And that's a figure which we look to improve by treatments. New mutations may increase virulence. D641G I've mentioned already, so surveillance is important. And there's no prior immunity at present. And so once again, for now, we lock down, we track, we trace and isolate, and we look for continuing surveillance as we buy time in order to develop effective treatments and vaccines. And that is the continuing battle that really has focused us again, given this uptick in cases in various places around the world. These questions are still highly relevant, and we need to go on buying time and really trying to limit the virus as much as possible. So perhaps a few minutes, if there are a few minutes, to look at how this relates to genomic medicine. Clearly, genomics has been at the heart of my interest, of Illumina's contribution to COVID-19, both reflecting on our experience with human genome sequencing for the host and looking at virus sequencing as well. And I just wanted to bring that together for a moment into the entire disease burden facing us and look at the prospects for how genomics plays such a central role. And this goes back to pre-COVID times, when if you look at genomics impacting rare disease or cancer, these are well-known cases where the host genome sequencing program started. That's why we've sequenced so many human genomes. We focused largely on rare genetic disease and on cancer. Cancer in particular, of course, being a big killer and a major disease of the genome. And cardiovascular, more of a multifactorial disease, of course, but nevertheless, there are genetic components. And if you look at the ability to sequence the host human genome, it's the same genome, whether it's any of these diseases, but the ability to extract the information from it changes. As you now overlay the present situation, of course, it is likely that almost everybody is exposed to some form of infection, and we're now perhaps seeing an increased mortality rate compared to some infection. Infectious disease also very important, of course, in the developing world. And so in people's lives, you can see here, if you see here three people's lives, you actually see some events. There's a cancer case at the bottom there, and you can see some limited testing that's done. And what we see in the future is the opportunity here, for example, for much more aggressive monitoring, particularly, for example, for cancer cases or prevention of cancer, but also the yellow arrows, which to my mind schematically represent tests for infection, and the possibility that one would need to actually significantly increase our infection testing, whether it's testing for something specific like COVID-19 during an outbreak or seasonal flu, or indeed both. And so we imagine that really as genomics takes over, it will really have an impact on all stakeholders as we move forward. So sequencing the patient's genome, whether it's for cancer or whether it's to look at the potential risk of infectious disease or an overreactive immune response, the physician's information is much more informed, and the healthcare system as well. So I think in the interest of time, I will end there. I'll skip over the last summary slide and just reflect as we take questions to the presence of Illumina. This just summarizes who we are, and a statement that was drafted, comes from our CEO on how we help fight COVID-19 and looking how we operate globally around the country. So at that point, I will stop and I'll leave this slide up, but I think it's up to somebody else to talk to me. Thank you very much for your attention.
Dr. Bentley, thank you very much for that presentation. That was really informative and you covered a lot of ground. We have a question from the floor, which I'd like to ask. Someone asked about whether you have any prediction regarding the potential for second waves in the US and other countries, and in such a case, how could they be managed by some of these potential treatments that you discussed? Also, do you expect that the demographics of the infected individuals will be any different in a second wave versus the first waves that we saw in February and March?
Great question, difficult to answer. I think first off, to go back to the early slides, we do see an upturn in some cases as a result of testing, and therefore we do anticipate, whether you call the upturn really a second wave at the moment or the extension of the first wave is perhaps open to question, but the clinical problem of course remains the same, and it probably doesn't affect the demographics. In terms of the demographic question, of course we do know, as I mentioned almost on the first slide, I think, that in some cases there are areas where people are living very close together, or people who have other comorbidities, and that is likely to continue to be a major factor. These are all new cases. This is not repeat infections at the moment. We don't know about repeat infections. I'm not sure if we've really seen them. So to all intents and purposes, all the cases in the second wave would be fresh exposure. I mentioned for the UK numbers, something like 8.5% of the population has tested positive. That means 91% is so far apparently negative and has not been exposed to the virus. So whether you call this a second wave because you've come out of lockdown and things have gone up again, or whether it's a second wave due to perhaps some new virus or new interaction remains to be determined. It is entirely possible the virus will continue to mutate, and therefore a second wave could be a new virus. The mutation I mentioned, D614G, in fact, arose during the last 5 months, I think sometime around February, March, and nevertheless has become extremely prevalent. And so there are waves of virus changes that might affect these. I think in terms of the host genetics, we'll have to wait and see whether genetics plays an important part of the susceptibility of the infection, or whether it is more to do with the severity of the condition, like the immune system. These individual variations remain to be established. Clearly, we have a little bit more ability to extract information as we move into the second wave, and in particular testing and surveillance early on to look at early containment while we continue to work over the longer term for better treatments.
Thank you, Dr. Bentley. Do you have any insight into whether the genomic methods could be used to help countries return to life as normal? For example, what kind of methods could be used to screen individuals returning to work or resuming sports competitions, and how would they be implemented?
So I think there certainly any tests can be used. I think if you're talking about people coming back to work or into sports competitions, clearly perhaps there are two things which are important. One is to have an immediate test, and that indicates the very high throughput, low cost tests, because you could be testing large groups of people regularly. You can imagine a test every week or two in a workplace. And really that has to be economical. It also has to be very sensitive. The other important test, of course, is the antibody test, and people vary about the importance of the antibody test. You might imagine if you have antibodies to the virus, you're good to go. You're resistant yourself. And if you're also negative for the virus at that point, you've had it and you're not going to spread it. That's a very good overall profile to have when you're going back to work. So I would argue that at the moment, having both an antibody test and a virus test, being positive for the antibody and negative for the virus, is the best possible outcome in going back to work, going back to sports competitions, because the risk of spreading it to somebody else and the risk of catching it are both much lower than if you don't have those results. Neither of those tests are perfect, as I've mentioned. The sensitivity is good, but not perfect of the virus tests. And the antibody tests, we don't quite know if they really mean you can't get it again. But this is much better than most of the current situations where we are simply managing and waiting to see if symptoms arise in many of these gatherings and situations. So I think systematic and fast turnaround testing, both for the virus and the antibody, remain the first and most important element. Surveillance of sequence for the virus is then very important to look at how to minimize and hopefully eliminate the sources of infection and change habits permanently.
Thank you, Dr. Bentley. As you mentioned, these genomics methods involve a lot of collaboration with different players in the public and private sectors in many different countries. I'm curious, are there any regulatory or legal challenges to the implementation of these methods?
Good question. I think in the diagnostic world, clearly regulatory approval is important. I think the regulatory authorities exemplified, in my case, from the FDA approval of the COVIDSeq test. This emergency use authorization accelerated the process while remaining, I think, to a high level safe, which is extremely important, and different nations will decide things differently. Of course, also in the diagnostic space or the clinical space, it is possible to operate not as a diagnostic, but as in a lab developed test, where the laboratory itself goes through a level of validation of the results and goes through a regulated process of approval. And that's using research use only reagents, and the burden of the registration falls to the laboratory's performance characteristics. So it varies from nation to nation. The German example that I chose was quite interesting because there the result was simply going back to the individual. So it's actually a direct-to-consumer kind of test and goes through a different concept of how this is then treated, because there will then be a follow-up process for the individual to undertake. So different levels of responsibility. Legal challenges I haven't really come across. So in that sense, that's less important than the regulation of safety and efficacy, which of course should be foremost in every nation's mind.
Thank you, Dr. Bentley. I think we have time for one last question from the floor, and I think this is one that is on a lot of people's minds. Do you have any insight on what the timeline for a vaccine might be? Could we expect one by the end of this year?
I don't. It's a very interesting field, and it's now a very complex field. I think I read that recently there are at least 200 initiatives around the world, all developing vaccines. One of the beauties of the era of molecular genetics, or genetic engineering, as we used to call it in the early days, is that there are now many different ways of doing it. It's not simply a case of culturing and inactivating the virus and injecting it back. There are ways of extracting pieces of the virus, growing it in culture, in DNA, and actually preparing large amounts of vaccine very quickly. The challenge, of course, is that the further you go in the genetic engineering route, the less like the original virus the eventual vaccine becomes. And so that is a question. There's a wonderful new strategy. It can develop a lot of material very quickly. But is it truly immunogenic? Is it truly specific for COVID-2 or other coronaviruses? And so these are rather open questions. So I think it's fair to sum up the answer to the question by the processes by which millions and millions of vaccine shots could be developed absolutely can be by the end of the year. How efficacious it is will remain to be the results of tests. Clearly tests are encouraging, people are seeing antibody responses to things, but that's different from actually immunizing a large number of individuals who then get challenged with the virus itself. That relies to some extent on the natural processes of infection, and obviously, of course, the test of a vaccine has to involve a person who has not previously been infected or immunized, who then gets the virus or then gets infected and has a resistance to it. That takes a long time. So I think we could see a number of vaccines being trialed before the end of the year. Quite whether there are winners in that process that get to everybody will be some time coming, and possibly some of the other technologies I've talked about today would help to govern the high-risk individuals who might be the ones who preferentially receive vaccines earlier than others, on the basis that quite a number of people actually are very healthy and do not.
Okay, thank you very much, Dr. Bentley. Unfortunately, I think we're out of time for today. If you'd like, I'd like to give you the opportunity to make some closing remarks. Yeah, sorry, I'm afraid we had a little bit of technical difficulty there. Okay, thank you very much, Dr. Bentley. This was a great discussion, and I think it was really beneficial for the audience. Before we close, I'd like to give you the opportunity to say the last word.
Well, I'd just like to thank everybody for their interest, and to really, I think this organization evokes such a wonderful example of those partnerships and collaborations that are really important. And indeed, the electronic communication makes things so much faster in terms of being able to get messages across to each other. Please do not hesitate if there are specific questions or specific examples. I am certainly available from the Illumina website, or indeed from the email connections you have if you would like me to answer any more questions or engage in further discussions. I'm just very, very pleased and honored to have been part of this organization and presentation today. So thank you very much.
Thank you very much, Dr. Bentley, and thank all of you for joining us. Have a great day.